Today I'm going to be discussing with you infections of the eye. So by the end of today's discussion, here are the learning outcomes. You should be able to discuss the spectrum of eye infections and their common causative agents, how they present, and the approach to laboratory diagnosis and management guidelines. So the eyes are immunologically protected, and we have the lacrimal apparatus that produces tears. The function of the tears is to constantly flush the eyes such that you don't have microbes being able to colonize the eye. In addition to the constant flushing function,
It's so
the
trash.
tears, yes, the tears also contain antimicrobial substances that would otherwise inhibit the proliferation of microbes. Apart from the functions of the eyes, the eyelids offer physical protection. So if it's a windy day and you have a lot of dust in the air, you go blinking on and off, closing your eyes. It's a form of mechanical protection. So the eyelids and the tears, they protect the external surface of the eye, both mechanically and biologically. As a result, any condition that can compromise these functions can result in an eye infection. For example, applying makeup frequently or sharing makeups, always fidgeting with the eyes, rubbing your eyes and things like that can mechanically inoculate organisms into the conjunctiva. So in terms of the spectrum of microbial agents that could cause infection, it's quite diverse. So you can have viral agents, bacterial agents, fungal agents, and parasitic agents. For the purpose of this discussion, we're going to discuss viral, bacterial, and parasitic agents of eye infection. In terms of clinical presentation, this is equally diverse. You can have conjunctivitis, which is inflammation of the conjunctiva. You can have keratitis, which is inflammation of the cornea, or you can have a combined inflammation of the cornea as well as the conjunctiva. So we refer to that as keratoconjunctivitis. And then you can have styes, which are essentially inflammation of the eyelids. You can have dacrocystitis, which is inflammation of the lacrimal glands or the tear glands. You can have canaliculitis, in which you have lacrimal canaliculi inflamed. Let's move on to specific eye condition. Now that we have an overview in terms of agents that could cause infection, in terms of structures that could be infected, let's see specific examples. We start off with conjunctivitis, and this is just a quick reminder of the anatomy of the conjunctiva. Remember that the conjunctiva is a thin, transparent tissue that covers the outer surface of the eye. It consists of two continuous parts, one on the inner surface of the eyelid, the superior tarsal conjunctiva, and the other over the sclera, the bulbar conjunctiva. Conjunctivitis is one of the most common eye infections that patients present with. It's also known colloquially as a pink eye or a red eye. And this is because when the conjunctiva is inflamed, it's the clinical appearance is like you have a pink or a red eye. So conjunctivitis is the inflammation of the inner membranes of the eyelids with associated discharge. Now, depending on the etiological agent, the nature of the discharge may vary from watery to purulent to mucopurulent or bloody. Conjunctivitis caused by bacteria or viruses are extremely contagious. And conjunctivitis can involve one eye initially, and before you know it, the patient has both eyes involved. In terms of the agents of infection, bacterial conjunctivitis is a common condition in children than in adults. However, in both adults and children, viral agents are important in the disease condition. Now, in terms of how the patient may present, although they are all pink eyes, but at times the underlying pathology differs. And if you look at the clinical presentation, you may have a rough or a presumptive idea of what you're likely dealing with. The patient may present with allergic conjunctivitis, and there's associated itching and redness of the eye with swelling of the conjunctiva and the eyelid. It could also be viral. With viral meningitis, there's redness as well with periodic itching, but there's increased tear production. So you have increased lacrimation. The patient will have a watery eye. With bacterial conjunctivitis, there's redness, then the patient will have a sensation of dry eyes and the skin around them. And then you can have purulent or mucopurulent discharge. There could also be conjunctivitis following a sexually transmitted infection. For example, we have chlamydia conjunctivitis, and we can have that due to Neisseria as well. Apart from STI, a woman who is infected and gives birth to a baby, the baby may also present with inclusion conjunctivitis. Then we also have what we call reactive conjunctivitis, which is due to irritants, usually chemicals, say for example, in the swimming pool. So here, I've given you a table showing the spectrum of agents that could result in conjunctivitis and important points to note about these agents. With adenovirus, you can have different types of the agents responsible, but the usual agents that are involved in clinical cases involving humans include types 3, 7, 8, and 19. You can have a systemic infection with conjunctivitis as a component of the infection. You can also have a situation in which you have an hemorrhagic conjunctivitis. This particular condition is associated with enterovirus 70 and Coxsackie virus A24. These are examples of Picona viruses. These are RNA viruses. With chlamydia, two different clinical presentations may occur because remember you have different serotypes of chlamydia. You have serotypes A to C, which are usually the etiological agent of trachoma, and types D to K, which are the agents usually involved in inclusion conjunctivitis. The Neisseria gonorrhoeae is an important agent of conjunctivitis because if you're not careful in management, the patient may lose the eyesight. Strep pneumoniae, Haemophilus influenza, they can cause purulent conjunctivitis, but this is usually seen in developed countries. Staph aureus, although may cause conjunctivitis, but tends to cause more of infections that involve the eyelids. In terms of epidemiology and in relation to age, Staphylococcus aureus is a leading cause of conjunctivitis in adults, whereas in children, organisms such as strep pneumoniae, Haemophilus influenzae, Moraxella catarrhalis are relatively more common. And if you recall from the lecture on otitis media and sinusitis, these are the three agents that are usually implicated in otitis media and um, sinusitis. The Haemophilus influenzae that we are talking about are the non-typable variant of the organism. It is important to note that in both adults and children, Neisseria gonorrhoeae is an important agent of conjunctivitis that can give rise to a particular condition referred to as hyperacute bacterial conjunctivitis. And because of the threat to sight, this is a condition that must involve a consult to the ophthalmologist. With viral conjunctivitis, the usual agent is adenovirus. And like I said, you have different serotypes that I've shown on the table. Now, with viral conjunctivitis, what I want you to note is that it could be a part of a syndrome. Like I told you, measles, you can have a systemic infection with eye manifestations, or you can have a situation in which the patient presents with just the eye infection. So you can have the conjunctivitis as part of a syndrome, or it could be a standalone presentation, depending on the agent you're dealing with. In terms of symptoms, the patient may come in with a complaint that I have a red eye, I have a pink eye. The patient may come in complaining that, okay, my eyes are tearing up. Or the patient may present with thick yellowish discharge, which is highly suggestive of a bacterial cause. The patient may tell you, I have a burning sensation in my eye, I have a sensation of foreign body in my eye, or the eyes are unduly itchy, or the patient may have swollen eyes. In terms of clinical presentation, trying to link it up to possible etiological agents. The patient that presents with a pink or red eye with a lot of tears is highly suggestive of viral conjunctivitis, as you have in the first picture to the right. With purulent conjunctivitis, you can see that you have this thick, purulent material. At times, you may have the eyelids shut down or matted together due to the presence of this discharge. With hemorrhagic conjunctivitis, you can see evidence of bleeding into the conjunctiva. So, how do you make a diagnosis? It's usually clinical, okay? But there are other more sinister eye conditions that could resemble conjunctivitis. For example, keratitis, iritis, and acute angle closure glaucoma may present with a red eye. So you need to rule out these other differentials in order to say that the patient has conjunctivitis. So you have to look out if there's a discharge, if the vision is normal, and things like that. So if the vision is normal and you have, say, watery discharge, that's highly suggestive of viral conjunctivitis. If you have purulent discharge, it's highly suggestive of bacterial conjunctivitis. If the eyes are bloody and you don't have evidence of these other differentials, you think of hemorrhagic conjunctivitis. So that's the whole idea of the clinical diagnosis. As a result, culture or staining is not so important in the diagnosis of conjunctivitis. However, when you are dealing with a patient with acute conjunctivitis, which is usually due to Neisseria gonorrhoeae, you need to collect swab samples that can be stained using either GIMSA or gram stain to demonstrate this gram-negative diplococci. Because, like I said, this infection is a threat to sight. What about the management? Viral conjunctivitis is a self-limiting condition. So you just have to encourage the patient not to not to use caustic solutions, because at times patients will do all sorts, herbal preparation, irrigating it with herbal preparation or some other solution. So you have to encourage the patient not to do something like this. It will resolve on its own. With bacterial conjunctivitis, again, it's also a self-limiting condition. Although studies have shown when you use topical antibiotics, it could shorten the clinical course, particularly if those antibiotics are administered before day 6 of the onset of symptoms. With conjunctivitis due to chlamydia and Neisseria gonorrhoeae, however, there is no self-limiting progression. You have to actively treat these conditions to prevent blindness. So antibiotic treatment is required for acute conjunctivitis when you have somebody that has Neisseria gonorrhoeae infection, that's hyperacute bacterial conjunctivitis, or adults who have inclusion conjunctivitis, which is usually due to chlamydia trachomatis. In another group of patients who use contact lens, it's also important to use antibiotics because you can have atypical agents now responsible for the eye infection. So in this particular group of patients, that is patients who use contact lens, you need to use antibiotics. In terms of prevention, remember we said at the beginning that bacterial and viral conjunctivitis are highly contagious, so they can spread readily. So what you have to do is encourage the patient not to share personal items such as handkerchief, tissues and towels, cosmetics, kneeling, or eating utensils. Now, with eating utensils, if you have a patient who has, say, for example, Neisseria gonorrhoeae, STI, you know there's going to be genital discharge. This discharge contains the organism. If this patient uses the bathroom and does not wash his or her hands with soap and water, and he or she handles eating utensils, these agents are dropped on the eating utensils. So if you're sharing eating utensils, it's possible to have cross-contamination. And if you are also in the habit of putting your finger in your eyes, then you can actually inoculate this organism from the index patient into your own eyes. So you have to encourage patients who have conjunctivitis to keep whatever they are using to themselves until the infection is resolved. So let's move on to another condition, trachoma. So we just discussed conjunctivitis. Trachoma is an important eye infection. It's the leading cause of infectious blindness in the world. It is estimated that approximately 84 million people worldwide are affected, and about 8 million of these 84 million have some degree of visual impairment. The disease accounts for more than 3% of the world's cases of blindness, and it is endemic in resource-poor countries, where prevalence rate is higher in children, particularly in children preschool age children, and this could reach like 60 to 90% of this patient population. Infection is usually acquired due to contact with contaminated flies, fingers, and towels. The organism that is responsible for infection is Chlamydia trachomatis serotypes A to C. So you have A, B, BA, and C. These are the ones that are responsible for trachoma. The disease condition itself is as a result of chronic repeated infections. So it's not a one-off thing, but it's because the patient gets exposed repeatedly, and the damaging effect of that experience results in trachoma. So infection is prevalent where there is poor access to water, preventing regular washing of the hands. As you can see here in the micrograph, you have this eye secretion and you have the flies feeding on this secretion. So these flies, when they leave this patient and they perch on another patient, they can actually transmit the agent. So what is the progression of trachoma? Infection starts when chlamydia causes inflammation of the conjunctiva. Say, for example, conjunctiva of the upper lid. As you can see here in this, you can see evidence of hyperemia, and you can see these swellings, okay? So this is the first step. The patient could have a resolution. If there is repeated infection, this can lead to inflammation and you have resolution. You can have what we call healing by fibrosis. So with repeated infection, you can have healing by fibrosis with contraction. So with contraction, you're going to have the pulling in of the eyelashes against the surface of the eye. So with time, these inturned eyelashes will scratch the surface of the eye, particularly the cornea. Infection and scarring of the eye surface may now follow because with repeated scratching, some microbes may infect the scratch wound. Damage to the eye surface is severe. You're going to have loss of vision as you have here in this patient and shown in this drawing here. So this shows you the trachoma, the progression of trachoma from initial infection through repeated infection that leads to scarring and contraction and eventual trauma to the cornea. How can you make a diagnosis? Laboratory diagnosis can be carried out using conjunctival fluid or scrapings. Both the fluid and the scraping are good for molecular assays such as polymerase chain reaction. However, if you're going to stain using James's stain, the scraping is a much more appropriate sample to send because the organisms are obligate intracellular agents. So collecting conjunctival fluid will not show anything on James's stain. But if you send in scrapings, that means you've taken part of the infected cells. And then with James's stain, we can actually see the intracytoplasmic elementary bodies of the agent in the cells. So this is diagnostic of trachoma. In terms of management and the prevention, you need to treat with antibiotics. Remember, we said there's an exception to the rule. Most bacterial conjunctivitis will resolve without intervention. If you use antibiotics, it can help shorten the progression, the duration of the disease if you give antibiotics within 6 days of onset of infection. However, in 2 cases, you have to actively treat the infection, and trachoma is one, and Neisseria gonorrhoeae conjunctivitis is the other. So treatment could be with a topical or oral antibiotics, depending on how severe the patient's infection is at presentation. In some cases, the patient may require surgery, and the basis of this condition, remember, is infection and reinfection, which could be facilitated by overcrowding, shortage of water, and abundant fly population. So in order to prevent infection, you can improve the standard of hygiene. So we talk about the safe strategy to the management and prevention of trachoma, where the S stands for surgery and the A stands for antibiotics. The F stands for face washing and hygiene education, and the E stands for environmental improvement. If the environment is clean and tidy, the fly population will drop. Apart from trachoma, inclusion conjunctivitis is another clinical condition involving the eye that is associated with chlamydia trachomatis. However, it's a different serotype that are usually attributed to inclusion conjunctivitis. These are the serotypes D to K. Inclusion conjunctivitis is the most common form of neonatal conjunctivitis, along with Neisseria gonorrhoeae. Because the two conditions, that is, inclusion conjunctivitis and Neisseria gonorrhoeae neonatal ophthalmia, could present the same clinically, you may not be able to differentiate between the two unless you focus on the history and you perform laboratory tests. So one of the things in the history that could alert you to maybe this is chlamydia and not Neisseria infection is the time of onset. With inclusion conjunctivitis, the clinical condition tend to appear between 2 to 25 days after delivery. However, with Neisseria gonorrhoeae, you have an acute situation, so it tends to present acutely within the first 2 days of delivery. So the time of onset may help you clinically to differentiate between ophthalmic neonatorium due to Neisseria gonorrhoeae from that due to chlamydia trachomatis infection. With inclusion conjunctivitis, you should note that the baby acquired the infection passing through the contaminated birth canal. So how do you make a diagnosis and prevent infection? Again, this involves swabbing a sample from the inside of the eyelid to test for the presence of characteristic inclusion bodies, like I showed you earlier, using Gemsa stain. Infection can be prevented by using antibiotic eye drops, such as erythromycin eye drops, in the newborn. Another clinical presentation that you can have is acute hemorrhagic conjunctivitis, which is associated with Picona viruses, particularly enterovirus 70 and Coxsackie virus A24. This is another clinical condition, just like trachoma, that is associated with poor hygiene. The infection is characterized by the sudden onset of bilateral conjunctivitis, associated with profuse watery discharge, lid edema, and fine punctate epithelial keratitis. So a prominent hemorrhagic component soon appears that is characteristic of this infection. In terms of treatment, there's no specific treatment being a viral infection. So management consists essentially of symptomatic treatment while you wait for the disease to fizzle out. It usually takes about 5 to 10 days for the disease condition to run out on its own. The condition almost always resolves without sequelae, having a good visual prognosis. So as scary as the eyes look, with the bloodshot eyes, it's usually resolves with a good prognosis. However, you should worry about secondary bacterial infection that may complicate the condition. So you have to encourage the patient not to stick fingers in the hands, not to use infusions that are not recommended by the doctor in the eye. Good personal hygiene can help prevent spread of infection. So again, this is not the time to share towels. This is not the time to share hankies and things like that. So we've discussed the infection involving the conjunctiva. Now we are moving on to eyelid infection, which are also known as stye or styes. This is a condition that is characterized by a red, painful lump near the edge of the eyelid, and it may actually look like a boil or a pimple on the lid. There are two types: the hodolium, which is usually secondary to an infective process, and Staph aureus is usually the agent associated with the condition. And with hodonium, you can have internal and external. So what I've shown here in the picture is the external variant. You can actually have this lesion developing in the lower eyelid. Then the second type of stye that you can have is called the chalazion. The chalazion is usually due to blockage of the Zeus and the meibomian glands. So it's not really due to an infective process, although in certain situations you may have secondary bacterial infection or invasion. So this is usually due to the blockage of meibomian glands in the eye. In terms of management, it's usually conservative. You just observe the patient. Most of the time, these lesions will resolve on their own. At times, you may need to give the patient some medication, and at times, you may need to intervene surgically. So, you need to send the patient to the ophthalmologist. Now, what predisposes a patient to this condition? Frequent touching of the eyes, sharing makeups, using makeups that can clog the glands opening and things like that are predisposing factors. So, in terms of preventing this condition, advise the patient, if possible, to stop the use of makeups. If the patient cannot give it up, then ensure that you don't share these items with friends and other family members. You should also discourage the patient from the habit of frequently touching the eyes. So we move on to a parasitic agent that is associated with eye infection, and that is Onchocerca. Onchocercasis is the disease condition that results when an individual is infected by this parasitic agent, Onchocerca. The organism is a filarial nematode. You know what nematode means? It's a round worm. Filarial means that you have the juvenile worms being responsible for the pathology. So the filarial nematodes, Onchocerca is involved in onchocerciasis. The clinical condition that results is also referred to as river blindness because the insect vector has been shown to breed near fast-flowing streams and rivers. The disease is prevalent in rural communities because this is where you won't have water supply and people have to go to the streams and rivers to fetch water. So the disease is prevalent in rural communities and it is a major cause of blindness and skin disease. The agent, Onchocerca is also responsible for a condition known as onchocerciasis-associated epilepsy in endemic areas, and you have serious socioeconomic consequences of infection due to this organism. Onchocerciasis is the second leading infectious cause of blindness worldwide. So it comes after trachoma, and you can actually have the epidemiology of the disease condition different in different regions of Africa. In West Africa, particularly the savannah areas are where you have relatively dry weather. You tend to have ocular onchocerciasis as a common feature of infection due to this agent. When infection occurs, it tends to affect the anterior segment of the eye, though the posterior eye segment can also be affected, particularly in heavy infection. The risk of visual impairment increases in part as the prevalence and intensity of infection in a community rises. The other epidemiological variant of infection occurs in the rainforest. So here you have higher humidity and you have dense, thick forest, as opposed to the savanna, which is a relatively dry area. In the African forest area, where you can have a comparable, that is similar intensity of infection as to the savanna area, onchocercal skin infection tend to predominate over ocular infection. And you have, as a result, reduced cases of blindness because the major manifestation is the skin disease. However, ocular lesions, when they are present, usually involve the posterior segment of the eye. Now, this difference between the savanna and forest epidemiologic patterns are thought to be due to the existence of two strains of Onchocerca volvulus, but this has not been demonstrated conclusively. The higher propensity for ocular disease with the savanna strain has also been correlated with higher quantities of Wolbachia DNA by PCR. Wolbachia is an endosymbiote organism associated with the worm. So this organism, Wolbachia, is found in adult worms as well as microfilaria. The microfilaria are the juvenile worms or the larvae. The organism has been shown to be essential for the filarial worm's fertility and survival. So without this endosymbiote, the organism cannot survive for long and it will not reproduce in a host. Now, why is there such an intense reaction that leads to blindness when you have Onchocerca volvulus that contain Wolbachia species? The reason is that when the organism Onchocerca volvulus dies, it releases the endosymbiote, the bacterium, say for example, Wolbachia pipientis, which is a common isolate associated with these adult forms of the organism. Because the bacterium itself can elicit an immune response in the human host, this immune response can result in itching and severe inflammation that can cause blindness eventually. So what is the life cycle of Onchocerca volvulus like? From this diagram, and if you remember from your POD lectures, this organism has an indirect life cycle because you need two agents to complete the life cycle. The life cycle starts in the human when an infected black fly comes for a blood meal. Remember that the black fly needs blood so that her eggs can mature. In the process of taking the blood meal, the microfilaria, which is the larval form of Onchocerca volvulus, are introduced into the skin. These larval forms will settle in the subcutaneous tissue and they develop and mature into adult worms. So the adult worms, once matured, will mate. So you have the male and the female worm in the skin nodule. So you usually have a nodule formed usually at bony prominences. When mating has occurred, the adult female worm is viviparous, so she's not going to lay eggs. What she's going to do is she's going to produce microfilaria, which are the immature worms. So these microfilaria are actually responsible for the pathology. The adult worms don't move around. They are found in the nodules, the subcutaneous nodules. However, these microfilaria can move around in the body. So thousands of microfilaria migrate through skin tissue, causing a variety of symptoms. So the symptoms include you can have skin diseases, you can have a skin rash, you can have skin pigmentation, or you can actually have the microfilaria migrate to the cornea, causing infection and inflammation that results in blindness. So here you have a picture of somebody with the microfilaria actually in the eye. Now, in a human who is infected, the microfilaria are present in the blood um, circulation. They are present in the tissue because this microfilaria can migrate and lodge in any tissue in the body. Another black fly that is not infected, when coming for a blood meal in an infected patient, is going to pick up these microfilaria. These microfilaria are going to develop through the L1, L2, L3 larva stages, if you remember from your POD lecture, until they get back to the L3 form, which is the infective form. So these infected black fly, when it goes for a blood meal, will start the cycle all over again. In terms of diagnosis, the skin snip is the gold standard of investigation. And here is a picture showing how the procedure is carried out. So you have a hypodermic needle, which you will use to gingerly lift up the skin. Remember, you don't want to cut down to the dermis, so you don't want bleeding to occur. Most of the time, these microfilaria are found in the epidermal layer of the skin or in blood sample. However, the site of the skin snip varies from region to region. Studies have shown that for you to get a very good result, if you are practicing in Central America, it is better to collect the skin snip over the scapula or the eyelid crest. If you're practicing in Africa, the pelvic girdle, the buttocks, and the external thigh are good sites from which you can collect the skin snip. If you're practicing in Yemen, the lower calf is a good site to collect the skin snip to demonstrate these microfilaria. In terms of management and prevention is based on vector control. Remember, this is a vector-borne disease. If you're able to get rid of the vector, you're going to break the life cycle. So prevention is based on vector control. So anything that can prevent humans getting bitten by the black fly, maybe through by wearing insecticide treated clothing when you're going to the river or the stream to fetch water, or actually spraying the environment with insecticides that will get rid of the insect vector. These are all approaches that you can use to prevent, to control the vector. Disease can also be treated in an index case, because if you treat the index patient and you get rid of the adult ones, there won't be microfilaria to infect the black fly. So that's another way in which you can both prevent and treat. So disease can be treated with an annual dose of the drug ivermectin. And now you can also add doxycycline to the treatment regimen. And the reason is this. Remember, we said that when the adult worms die, they release the endosymbiote, the bacterium or bacteria. So if you just give ivermectin and the adult worms die, the bacterium is still going to be released and you're still going to have that severe inflammatory response that can lead to blindness. So in addition to ivermectin, you give doxycycline to kill the endosymbiotic uh, bacteria. So that will reduce the amount of inflammation that will occur. Another advantage of treating with doxycycline is that when you kill the endogenous bacterium, the female Onchocerca volvulus worm becomes sterile. Remember that we said this agent, this bacterial agent, is needed for maturity, reproductive maturity of the adult female worm and the microfilaria as well. So if you treat with doxycycline, apart from reducing the inflammation that could result following the death of the adult worms, you are also going to render the worm sterile. So you're in essence breaking the chain of transmission. And that's it. Any question?
Yes, doctor, there's some questions in the chat.
Yes.
Okay.
Chalazion is internal, right? It could be internal, it could be external. Oh, you can have external or internal as well. We are talking about the glands. Okay, just a minute. You don't get Huda, the management of which one of them?
Which one, doctor?
Which one of the conditions? We've discussed trachoma, we've discussed inclusion conjunctivitis, hemorrhagic conjunctivitis. We've discussed which
Doctor,
other
I
one?
think you're talking trachoma.
Trachoma. Okay,
Yes.
so you don't get the management. Now, remember that with trachoma, the main problem is you have repeated infection. The progress of the disease is that you have inflammation in the eyelids. It's going to heal, then you're going to have scarring. With scarring, the eyelids are drawn inwards, so the eyelashes are going to be rubbing on the cornea. And then with time, you're going to have abrasions on the cornea, which can eventually lead to blindness. So what we're saying is, if you can prevent repeated infection using the safe approach, okay? The safe approach, if the patient has infection already, repeated infection already, and you have, the eyelids drawn in, you can perform surgery to make sure that the lashes are no longer, causing an abrasion on the skin surface, on the eye surface. That's one approach. The A is the use of antibiotics. Remember that with Neisseria gonorrhoeae and chlamydia, you need to actively treat. This is not the time to employ the wait and see approach. Okay? The F, okay, is to make sure that the patient has frequent washing of the eyes, so there's adequate provision of water, personal hygiene is improved, and things like that. And then the E has to do with the environment. So you have to improve the environment in terms of hygiene, because when you have a dirty environment, that's when the flies that are responsible for transmitting this agent, that's when they have a time, the right environment to thrive and multiply. So if the environment is clean, you're not going to have a high fly population that will transfer infection. So is that clear? Huda?
Mm.
Huda, is that clear? Do you want me to go over it?
Yes. Dr. Huda says yes. Clear.
Okay, thank you. What are the stages called? What stages?
Doctor, for trachoma, I think. Yeah. I think these are
For
all.
trachoma?
Yes.
What do you mean by stages? Okay, let me go back. Because we talked of the disease progression. So you have infection, Okay,
Yeah, doctor, I think this
then
one is clear. Yes.
this is clear now. Okay,
Doctor, this is
can
the
you go
slide they asked
over
about.
progression?
Yes.
What?
This is the slide they asked about. The slide on the screen right now. This is the slide. Yes.
This is the slide.
Yes.
Yes, okay. What I said is the initial infection is characterized by inflammation, and you can see the red, angry looking eyelid here, inverted eyelid. And then you can see some, um, like, nodules formed. Okay? This can resolve on its own with or without treatment. Okay? Particularly if this is the first infection. But the problem is because the environment is dirty, the patient have compromised water supply system, the infection reoccurs. So the flies will come again. So with repeated infection, you're going to have healing by fibrosis. So healing by fibrosis is going to result in scarring because this is not the normal tissue that is found in this area. It's like you now have fibrous tissue being formed. With time, fibrous tissue will shrink or contract. So when that happens, the eyelashes are going to be rubbing on the corneal surface. Eventually, you're going to have tiny ulcers that will eventually lead to loss of vision. So I don't know if these are really stages, but rather progression. So, the situation gets worse over time. So I've gone over the progression. So I don't know if it's right to say there are stages. It's just to give you an idea. For example, if you see a patient, uh, what have I done? If you see a patient, say at this stage where you now have scarring, you know that this patient has undergone repeated infection. If you see a patient at this stage where you have mainly inflammation, you know that this is just the onset. Your intervention will probably save the patient's eyesight. At this stage, if you have scarring and you have pulling of the eyelashes, you may need to offer the patient surgery so that the patient does not progress to the inturned eyelashes stage or state. Okay? Can the doctor please repeat slide 20? Okay. Okay, that's what I just discussed. Okay. The eyelashes will be inverted and it will damage the cornea, causing injuries, which will open the way to infection. Yes. You know that usually the tears will lubricate and get rid of whatever is there in the eye. The eyelashes will mechanically protect the eye. Now, the function of the eyelashes are being compromised because instead of protecting the eye, they are actually traumatizing the eye. The moment the eyelashes are pulled in, it's no longer offering a mechanical protection, rather, it is now acting like an abrasive device. So you're going to have repeated um, injury to the cornea, and that may allow secondary bacterial infection, or you may have healing by fibrosis. There'll be inflammation, and then resolution of that will result in a cloudy cornea.
Thank you, doctor.
Okay. Uh,
Uh,
so, doctor, the problem in ulcer or that there will be another infection. Okay. The problem is you have repeated infection. I want you to get this right. The ulcer is at the tail end of the disease progression. What eventually leads to the ulcer is the fact that you're going to have repeated infection that will result in scarring. The effect of scarring on the eyelids is that you're going to have the eyelashes drawn in. These indrawn eyelashes will now traumatize the cornea So like I said earlier, instead of offering that physical, that mechanical protection, it's actually now causing injury to the eye. Is that clear?
Yes,
Do
doctor.
we? Okay. Doctor, what do we need to focus on regarding all your lectures? For example, basics of clinical aspects. Okay, I always give you the learning objective, okay? Because my questions are going to be based on the learning objective. So today we've discussed the spectrum of eye conditions that you could have. So you can have infection involving the conjunctiva. We discussed that, right? Then I discussed specific examples that could result in conjunctivitis. So we talked about trachoma, inclusion conjunctivitis, hemorrhagic conjunctivitis. Okay. Then we discussed the parasitic infection. So in terms of how these conditions may present, you may be asked anything. You may be asked something on management. We gave an overview of management. Okay. So these are examples of what to expect. Questions could come on maybe disease presentation or the etiological agent and things like that, or the laboratory intervention. So those are things we discussed. Okay. Um, so if you are to focus on anything regarding my lectures, let my learning objective or the learning outcome be your guide. So, doctor, the problem, okay, I think I've answered that. What about the DNA of Oncosarca? I don't understand this question. What about the DNA? What do you mean? Are you referring to this slide? Let me go over what I'm trying to say here. I told you that the organism Onchocerca volvulus has different presentation. If you have the African savanna and the rainforest, the disease presentation in these two regions are different. Now, there are some hypotheses. One is that you have different strains. So that is trying to say that, okay, you have a more virulent strain and a less virulent strain. But I told you, we don't have anything conclusive to really say that there are two different strains. But that is one of the hypotheses. Okay. The other thing is that studies have shown that the organism Onchocerca volvulus has an endosymbiotic bacterium. That's the Wolbachia. Okay? Now, the Wolbachia, the amount of DNA of this organism present in Onchocerca volvulus can be assessed. So, when assessed, the higher quantities, those organisms that have a higher number of the endosymbiote associated with them can give rise to those conditions that result in blindness. Is that clear? So the higher the number of bacterium, endosymbiotic organism on the worm or in the worm rather, the higher the propensity to cause ocular disease. So if you have more DNA, that is highly suggestive of more bacteria or a higher colonization of Onchocerca volvulus by Wolbachia. Am I making sense now? Are you clear now?
Yes, doctor. Thank you.
Okay, thank you. Any other question? Okay, wait a
Doctor,
minute.
yes.
Yes,
Do
I
they
think I
have
have
to
the
know the life
direct
cycle of
message.
Onchocerca? That's one of the questions.
Pardon? Pardon? Just a minute. I think I have a direct message. I can't seem
Yes.
to get it. Can't seem to open it. There's a direct message I can't access. I don't know what the content is. I don't know. The person who sent the direct message, can you just send it as anonymous to the regular chat? I can't access it. Or has your question been answered? You can unmute yourself to ask your question actually. Okay. Any other question? So enjoy the rest of the day. I wish you the best in your exams.
Doctor, someone
Bye.
asked if they have to know the lifestyle of Oncosarca,
If they
the life cycle, sorry.
nah, that's POD stuff.
Okay.
Now no, so no.
Okay.
But it's nice to know how to make a diagnosis. It's nice to know why you have a difference in presentation between savanna and forest infections, things like that.
Mm-hmm.
And that's
And
it.
doctor, are purulent conjunctivitis and inclusion conjunctivitis the same?
No. Inclusion conjunctivitis is due to a specific agent, Chlamydia trachomatis. Okay? Bacterial conjunctivitis could be due to Staph aureus, could be due to strep pneumo, could be due to Haemophilus. Okay? Is that clear? Okay. Any other question?
Okay. No more questions, doctor. That's it.
Thank you
Thank you
so
so much.
much. You're
Thank you, doctor.
welcome. Bye.
Bye.